Did you answer? Hi, everyone. My assistant and I would like to welcome you to today's webinar presentation with my good friend, Brandy Brimhall, who is going to be answering all of your burning questions about compliance, billing, coding. Listen, she has been there and done that. She's been working in the chiropractic industry for over 20 years. She is a certified professional coder. She is a certified professional compliance officer. She's a certified professional medical auditor. She knows it all. And if she doesn't know it all, she knows how to find the answer to your burning questions. So without further ado, welcome, Brandy. Thank you for being here today.
Thank you so much. And thank you everyone for taking the time to spend with us today on some common questions and answers. I've been anxious for this particular topic because I have the help desk, which is it's an on-demand virtual chiropractic assistant, and I'm your on-demand virtual CA that's certified in coding, billing, collections, auditing, and compliance. And through my Help Desk portal, I get questions of lots and lots of different topics from all across the country. So today I put together several to go through with you that are common questions that I'm getting. And I think it's going to be useful because I was actually, just before I sent my slides over to Christy, really rearranging them a little bit to update to some of the more common questions I'm getting right now, because practices are in a unique position today that all of a sudden we have some extra time on our hands. We're concerned about our numbers. What do we need to do to help our practices as best as we can to get through this challenging place that we're in? And of course, that comes down to our billing, collections, and accounts receivable system. So I'm going to approach the questions, or many of them that I'm getting on these topics right now, to help practices, that ultimately is helping a lot of practices bring in some of that old stagnant money in a matter of days to a matter of weeks. And we'll cover some other things too, but I thought this would be useful for you in just being able to, once we finish the webinar, you have some immediate action steps, the things that you can do or questions that you can ask to whomever is responsible for some of the revenue cycle pieces to your practice. So the first thing I would just share with you is, as we know, we have to have patients in our office to really keep things moving along. But the other part to that I really see as the lifeblood, or the nervous system to your practice, if you will, is the entire revenue cycle system. And there's a lot of moving pieces to the revenue cycle system. And of course, as we know, and as we educate our patients, if there's interference in any of those systems, as far as our patient's nervous system, then of course there's going to be other signs, symptoms, and challenges the patient will present with. And of course, the longer that they have that interference, the more time consuming and sometimes more severe those challenges and symptoms are. The same thing applies to your revenue cycle system. And so we're just going to focus on some of those questions that I'm getting today. One of the things that I would encourage you just to keep in mind is time is money. And that's one of the things that I love about my Help Desk is I'm also not just able to help practices with these many questions that they have, but save them time, because having been a CA in practices myself, I know that we're busy, we have a lot to do, and sometimes we don't always have the adequate training that we need in order to be able to know who to ask or where to find an answer. And a lot of times we don't have the time to do it. So we're left with setting things in our to-do later pile, which I'm sure that we all have one of those, or we find ourselves guessing, which of course increases the chances of our guess being wrong, which means it's losing the practice time, money, and other things along those lines. So we're going to address that, but that was certainly one of the goals that I have in mind when I started working with my Help Desk, to make sure that I could help practices from my perspective and with my skill set as best as I possibly could. So we're going to look at the pieces to the revenue cycle system, and these are questions that I'm getting a lot, is what do I need to look at to be able to see where my money is sitting stagnant, where it may be slipping through the cracks. And so I'm going to share that with you on this particular slide and give you some checklist items, if you will, of things that you can immediately go to look at with your practice to start to get that money back moving. And again, there's so many questions that I get of varieties of topics, but we're going to focus on the money making and revenue cycle system part today, because that has been the priority for just about every question I've had coming in over the past 3.5 weeks or so. So the first thing I would suggest to you is claim scrubbing. You want to make sure that you're submitting clean claims, which means make sure that you are submitting claims that have adequately supported your documentation. Of course, as we know, tells one story, your coding tells another. But keeping in mind, too, that you need to make sure that you're properly diagnosing for the services that you're rendering, or you could perhaps receive claims rejections, denials, delays, and that type of thing. So make sure that you know how to use those modifiers. I'm going to give you a couple of examples today of some common ones that I run into. Make sure that you're submitting your claims regularly. So practices need to have a scheduled time to make sure that their claims are submit. Just like your patient, when they come into your office, they schedule time to see you. I believe that the moving parts to the revenue cycle system deserve scheduled time and attention so that you can avoid those errors and oversights that ultimately is costing your practice time and money. Now, the first thing that you can do for our checklist item is go through and pull your claims rejections. Claims rejections are really important because this is where your practice is submitting electronically through a clearinghouse to your third-party payers. Any of those claims that aren't clean, meaning that there's some type of error on the claim, are going to reject back to your system. I have come upon many, many practices who simply forget or overlook pulling those rejections and correcting them. Rejections are one of those things that it's almost an out of sight, out of mind type of thing. And because of that, there's a lot of lost and stagnant money sitting right in your rejections. So the first thing I would suggest to you today is check with your staff, with your biller, whomever is responsible for getting your claims submitted, to make sure that they are pulling rejections regularly and make sure that they're checking them. And I'm going to give you more information on that as we move forward. The next thing that's really, really important is it's so critical that practices learn how to read the EOBs. And by that, I mean doctors should always know, because ultimately you're either blindly trusting someone or you're trusting someone who you know has had adequate training to make sure that they're reading your EOBs properly. What I mean by that is line item by line item to make sure that you aren't having an unusual rejected line item or delayed or denied line item, or you're requested for records or something along those lines that is causing your practice to lose money because it isn't being followed up with properly. And I actually have several EOBs that I pulled for this particular webinar that I'm going to share with you and give you a true real-time glance at what is being found in practice EOBs. And these are EOBs that have been shared with me by practices, CAs and doctors and billers that have come upon some kind of issue in their EOB that doesn't make sense to them. So I have saved some of those to share with you today, because chances are if I'm getting that many questions on these kinds of issues with EOBs, there's probably a good portion of you that are finding many of the same things. And what we don't want to have is that you're finding them and either no one is doing anything about it, or you're not aware of it, and therefore they're just being posted as is and moving on, causing your practice to lose money. You also want to make sure that you have good follow-up and appeals. So going through your accounts receivable report is something I'm going to share with you a little bit today, because it's amazingly diagnostic for your practice, and making sure that you have a good system in place. And again, making sure you have scheduled time and attention to it. Right now, a lot of practices have more time on their hands, so there's really almost no time like the present to begin to really delve into this and make sure you're getting that money moving. But if there are calls that need to be made, if you need to log into a provider or a payer portal, rather, make sure that you're doing that to make sure you're putting touches on that money. You should have touches on that old money to make sure that it's been looked at. If there's a next step to be taken, it's been taken or attempted, so that you can keep that money moving. Because ultimately what you want to do under right now and all the time in your practice is to prevent that money from getting stagnant. Because like with everything else in life, water, air, blood, all of those things require motion in order to be alive. And the same thing applies to money. So we want to make sure that we're keeping that money moving in every way we can. And that's why we're going through some of these moving parts of the revenue cycle system for practices that oftentimes we don't think of. And again, these are questions that are coming in just by the floods to the C Help Desk as to what should I look at? What should I do? What's an action step that I can give to my CA or that I can take myself to make sure that we're getting some of this money moving, because it just isn't making sense to us how we haven't been paid for some of these things up to this point. What can we do? So that's why we're covering that today. As I mentioned already, your accounts receivable report is an amazing and fantastic diagnostic tool and truly helps every practice have a better finger or handle on the pulse of your practice. And so knowing what to look for, how to look at those, and how to manage those in a very efficient manner is going to be beneficial to you. Again, bringing money in a matter of days to a matter of weeks, starting right now, but moving forward. The next thing I would just suggest to you, because communication is always critically important, and most of the time when I'm getting questions from doctors and CAs through the C Help Desk, a lot of the times it's, I thought this was being handled, I assumed this was correct, and it's really a lack of communication. So I would suggest to you to really consider the communication systems that you have in your practice right now, because not every error or oversight by any means can be mitigated or prevented by increasing and improving communications. But I would definitely dare say that a sizable portion of that could be eliminated, avoided, or at least minimized just by making sure you have sound communication systems in place, which means you're asking questions, you're being asked questions, you have a way to meet or to document when you're communicating. Some of my practices, actually when I was a CA, some of our other CAs liked to use sticky notes, and those kind of drove me completely batty because they got lost. It was abbreviated notes, and who knew when it was put there or how to follow up or who to follow up, that kind of stuff. So just make sure you have a reasonable and effective system in place. If you find that your communication system is a bit clunky, my best suggestion to you would be the worst thing you can do is nothing, but there's all kinds of different ways to improve communication and really identify and hone in on where the communication lapse is, and make sure that you put some pieces or steps in place to minimize that. So going back to the checklist items that I talked about, because I get asked a lot about claims rejection, so I'm going to share with you first how the rejections really work, and then some common rejections that are happening, because ideally you want to know that you need to pull your rejections and look at them. But the next thing is there's several things that you can do to minimize the number of rejections you're getting. So I'm going to share with you what those common ones are that I'm running across all the time. And that's going to help you and whoever's in charge of submitting your claims to be able to, avoid getting those rejections, because a rejected claim ultimately is a claim that is going to be sitting there stagnant until you get your hands back on it and can figure out first why it was rejected, and then make the correction and push it back through. So that's at the very least delayed money. We don't want to take any chances that we possibly have to on having any delayed money in our practice right now or ever. So let's look at the rejections. The first thing, as I mentioned, rejections is claims that you're submitting electronically that are rejected either by the clearinghouse or by the payer. And the rejection simply means there's something wrong with this claim. And until you correct it, it's not going to be able to be resubmit or processed properly by the third-party payer. So there's two places that can actually reject your claims. The first one is the payers. And what happens with the payers is the clearinghouse pushes the claim through, because from the clearinghouse scrubbing systems, there's not an error to be found. However, once the claim arrives at the payer can often reject claims. And the reasons they do are a couple of things. The first one is for in the event the patient can't be identified. So my suggestion to you, because almost every time this happens, there's either a missing digit or character or a transposed digit or character in the patient's policy number. So you want to make sure that you're paying attention to detail and just being either paying close attention or giving those policy numbers a double check once the patient's insurance information is entered, because it will reject by the payer, citing that the patient can't be identified. Another rejection that's common for payers is that the patient's insurance has terminated. So the patient is no longer covered, and payers will often electronically reject those claims because the patient is no longer covered by that payer. This can easily be avoided by just simply making sure you have good sound systems in place to communicate by phone or at the front desk with your patients, asking them to provide their current insurance information, or if the insurance information you have on file is correct. The most common time for this type of rejection to happen is usually the first quarter of every year, because most of the time when there's a change in payer, then that happens at the beginning of a new year. Not always, but most of the time. So it can easily be avoided, but it's happening an awful lot now. So I'm hearing from a lot of providers that are in a position that they're having to reach out themselves or have their staff reach out to patients, sometimes leaving many voice messages, several attempts to call and reach the patient to get current insurance information for billing. And of course, time is money. So your claim is delayed. You have nowhere to submit it. What I like to do when this happens, if I've reached out to a patient and they're not returning my call after the first call or two, I simply transfer that balance to the patient, make a note in the patient's account why I have transferred that balance, and I invoice the patient immediately, because it is motivating for them once they get an invoice to reach out and address it. Not always, but it's certainly more successful than continuing to try to call a patient that isn't returning your phone call. So make sure you look at those payer rejections. The other thing I would tell you with payer rejections is Blue Cross Blue Shield prefers also to have the policy number and the group number in the claim. So that should appear on your claim form. I've come upon a lot of practices that sort of like to shortcut it and put only the policy number, only to find that their claim is rejected by Blue Cross, citing that the patient can't be identified. But when we check the card, the policy number is correct, but there's a missing group number. So a good best practice for you would be just to make sure that when patient's insurance information is being added, it's the policy number and the group number that's being added to the claim, so it can go through the first time properly, so we're not losing time or money. The next thing I would share with you is our clearinghouse rejections. Those happen with the clearinghouse scrubbing system, and this is just ultimately, the clearinghouses have limitations on what they can look for, because basically what they have the capability of looking at is every field properly populated, and are there any diagnoses in the claim that are obsolete or no longer valid? So those are things that clearinghouses can look for. So a few things that you can expect on clearinghouse related rejections is in the event that you have a misplaced modifier. So a fantastic example of that is United Healthcare requires the GP modifier, it's the outpatient therapy modifier, to be appended to every single outpatient therapy that's billed to United Healthcare. And again, make sure that you note this specifically for United Healthcare, because if you add the modifier to other payers, your Blue Crosses and Cignas and that sort of thing, you're going to be rejected, and then you're going to be upset that it happened. So just United Healthcare outpatient therapy. So your e-stim, your therapeutic exercises, therapeutic activities, NMR, manual therapy, all of those types of outpatient therapies, append your other proper modifiers if it's applicable. For some of them it is, and then of course the GP letting United Healthcare know this is an outpatient therapy. That will cause rejection if you're missing the GP modifier. Also, you could be rejected by simply not having the patient's, sometimes patient names. If you have a Robert, but the system says Bob, that could reject because of an incorrect patient information. So make sure that you understand those types of rejections. If you're using diagnosis codes that are not valid or are no longer, in fact, some practices I'm still running into are adding digits to the end of their diagnosis to indicate laterality. Please don't do that if the diagnoses aren't defined that way to start with, because that will result in a rejection citing that the diagnosis is invalid. So make sure that you have that. You can also get rejections for misrouted claims. And so you can be sending a claim to Blue Cross Blue Shield, for example, when it should be going to ASH. That's something that can easily be avoided by just making sure you verify your benefits and you're routing your claim to the proper payer. So look for those types of rejections, and you can avoid a lot of them just simply by making sure that you know these things in advance, like I'm sharing with you now, but then you're proactive in checking your claims properly to make sure that they're going to be submitted. The next thing I would share with you is because paper claims, electronic rejections, we have an advantage. If you're in the habit of pulling them down regularly and making the corrections, that's fantastic because the delay is at least minimal in that case if you have a good solid system. The challenge is a lot of practices, myself included, submit paper claims also. If you have a claim that's incorrect, then a paper claim is going to take 3 to 4 weeks to come back to you, only to tell you either in a letter or on the EOB that something was wrong with your claim. So this is why having good claim submission processes in place, meaning give your claims one last glance before sending them out to make sure, yes, I have adequately diagnosed for my services. Yes, I'm certain that the diagnosis I'm using are current and active. Yes, I feel comfortable that my modifiers are appended in the proper place to the proper codes. Yes, I have checked the patient's policy and group number, and that's been included onto my claim. Those types of things are really important to quickly look at. Only takes a couple of seconds, but you can find and fix your own errors before a payer does, and it's going to save you time and money. So definitely keep that in mind with your claims rejections, but truly, this is one area I have been spending so much time on over the past, I spend time on it all the time, but over the past few weeks, I've been spending an awful lot of time on it. So definitely, I'm expecting that at least some of you will find some lost money or stagnant money rather right there in your claims rejection. Okay, so some other things that I'm being asked about is what else can we do in our practice, because we're learning to look at EOBs, or we've been looking at EOBs, and we're finding that we're having issues in other places that's causing us to, even though sometimes we even see the same amount of patients, we're losing money. How on earth could this possibly happen to us, and what can we do to prevent it from happening in the future? So this is where we're going to spend some time going over controllable errors, and these are errors ultimately, just like it sounds, errors that are commonly happening in practices that if you know in advance that it's something that could potentially occur or it possibly is occurring in yours, you can address it now and prevent it down the road. So let's go through that list. The first one is exceeding insurance limits, and this happens to an awful lot of practices that just simply haven't verified their benefits. So definitely can't stress enough to you how important it is for you cash flow wise. I know sometimes it's annoying and it takes a little bit of extra time, but verify your benefits, because if you're not, I could almost promise you that at least somewhere in your patient volume, you're losing money in insurance simply because you don't know what the benefits and limitations are. And nobody wants to lose money. So the first one, exceeding insurance limits. So we have a patient that has 12 chiropractic visits per year, but we don't find out until we've received the EOB for visits 13, 14, and 15 that the patient has exhausted their benefits. So now you're in a position that you have to, if you even can, depending upon the network agreement, transfer charges to the patient, invoice the patient, and then perhaps you have an upset patient because they feel like they've been misled or not properly informed of what would be their own responsibility. So then you're taking the time and money to invoice your patients, or in some cases, you're not able to bill the patient and you ultimately just treated the patient for free. So that's something easily avoidable, but happens all the time. Keep in mind too that chiropractic benefits, therapy benefits, E&M benefits, your x-ray benefits sometimes can fall under different parts of the policy, meaning there could be different policy benefits and limitations for those 4 categories. So it's possible a patient may have 12 chiropractic visits, yet they have 24 therapy visits allowed, which means if you know that in advance, you can go ahead, as long as it's medically necessary, once the patient has exhausted their benefits for chiropractic, as long as therapies continue to be medically necessary and the patient is receiving those therapies, you still have additional benefits that you could be getting paid on. A lot of practices don't know that and they miss it completely. And that's a considerable amount of lost income. So knowing those benefits really, truly will make you more money. Next, no authorization for a specific date of service. And I actually have an EOB that I brought today to share with you as to why this is so critically important. So some payers out there, as we know, require pre-authorization for treatment. What they don't do most of the time is allow retroactive authorization, meaning once you find out after the fact you had to have authorization for care, they're not going to give you authorization for the visits that have already taken place. Most of the time, these are in-network providers, and because the claims were processed, because the patient was treated without authorization, most of those EOBs are going to require that the practice adjust off those charges, which means any balance you've collected from the patient could have to be refunded. And also, you're not going to get paid by the insurance company. And that's a horrible and frustrating thing to find out after you've already been seeing a patient. So verify the benefits so that you know what to expect and what your requirements are as a provider, so that you're not losing money by not getting pre-authorization for care. The next one here is using codes that are not authorized by an insurance company. I have one example here in mind for you to share today is our eSTEM code. 97014 is our most common eSTEM code that we use for billing. However, it's been a few years now, but United Healthcare has said we're no longer going to allow the 97014 for eSTEM. Instead, we want you to use the HCPCS code, which is G0283, because it's more specific. So this is an area, and actually quickly going back to rejections, if you submit the 97014 to United Healthcare, your electronic claim will reject, citing that there's an inappropriate code. If you submit this claim to United Healthcare by paper, you're going to get a denial 3 or 4 weeks down the road, letting you know that that's not a covered procedure. Don't make the mistake of just assuming that eSTEM isn't paid for. When it's medically necessary, so long as coverage and benefits allowed, it is a reimbursable code. I get reimbursed for it all the time. So does most of the doctors across the country, so long as they're billing the appropriate code. So don't make that mistake. To United Healthcare, submit the G0283 with your GP modifier. To other payers, go ahead and submit your standard 97014 unless they specify otherwise. But make sure you're using the appropriate code. If you find, and this happened just, 3 or 4 days ago, I had a question on the C help desk of a provider that actually said, hey, I've actually been denied for the 97014. I just thought there wasn't any coverage. I just noticed this. What can I do? What you can do is still be reimbursed for at least some of those denials. What you'll do is simply print off your claim, or if you can correct it electronically, then by all means do that. But it's a corrected code. So you remove the 97014 and you replace it with the G0283, append your GP modifier, and submit the corrected code. You're going to find that you're being reimbursed for that so long as there's coverage and benefits, of course, by that under that particular policy. But you don't want to lose money by just not simply knowing that there's a better code or a required code that you should be using. The next thing on the list here is improper use of modifiers. I actually have a couple of EOB examples for you on this one, but just to quickly recap, one controllable error is simply not using the appropriate modifier for your new patient exams and re-exams. And so, of course, as we know, if you're adjusting the patient on the same day, you have to append the 25 modifier to your exams and your re-exams, indicating this is a separately identifiable evaluation and management procedure. If you miss the 25 modifier, that line item is going to be denied, that it's citing that it's incidental to another procedure. I've run across several EOBs that have been sent to me with this actual denial taking place. And meanwhile, the practices didn't recognize that they were missing a modifier and instead just assumed that they were going to have to appeal it, and they didn't want to have to go through any appeals process, so they closed the charge. And all the while, simply by just submitting it with a proper modifier would have resulted in proper processing and reimbursement. Another example, again, is the GP modifier with United Healthcare that I mentioned. If you're getting rejections from United Healthcare electronically, check to make sure that the GP modifier is appended to all of your outpatient therapies. And that's, making sure, again, that you're using those modifiers properly. Another controllable error regarding modifiers that I would just quickly tell you is our 59 modifier is one of those that it's actually the most misused modifier in all of healthcare. And it's because it's sort of ill-defined and can be used for a lot of different purposes. So practices, and not just chiropractic by any means, but have just sort of decided, I don't really know exactly where to append this, so I'm just going to slap it everywhere and hope for the best because, I'd rather have it in too many places than not enough places. My suggestion to you is there's not that many codes where the 59 applies in our chiropractic offices. However, by using it or overusing it in too many places is likely down the road to cause other problems for you. It could be denied claims or rejected claims, but what I'm coming upon more often is simply claims that are where there's records requested because there's an unusual use of modifiers indicates to a third-party payer or processor that there's something awry with the coding because it's not making sense. And over time, those types of patterns are recognized by processing systems, which can prompt records reviews, records requests, and things like that. So again, time is money. The best thing that you can do for your practice is your due diligence now to make sure that you have those ducks in a row so you're more confident in your code selection, you're submitting clean claims, and you're not unknowingly putting your practice at greater risk or causing your claims to reject, delay, deny, and all of that sort of thing. The next question I'm getting is diagnosis. I've had some claims recently that have come back because of unusual diagnosis. Let me explain real quickly how diagnosis pointing is so important. First, we know our service codes say what we're doing. So this is the procedure I'm rendering to the patient. Our diagnosis codes say why we're doing it. So it's sort of like writing a sentence in a novel or in a book that I'm doing this today because, and that's exactly my services rendered today are this, and this is the condition or symptoms that they're rendered for. So your diagnosis pointing is critically important because your third-party processor doesn't have the advantage, and even if they did, wouldn't often take the time to read all of your notes to understand what's really taking place and why. And medical necessity is really important to them to make sure that they are paying claims that truly should be payable. So your diagnosis pointing is your only way to communicate with a third-party payer. This is the procedure I'm rendering, and this is the condition and symptom, or these are the conditions and symptoms as to why this procedure was necessary. And I've come upon, especially lately, some denials from some payers simply because it's unclear which procedures were performed for which purpose. And I've also come upon some denials on individual line items, citing that one or more procedures was incidental to another procedure, meaning either one of these procedures could have been performed and accomplished the same thing. So you don't want to do that because then you're not getting paid for one or more procedures. So making sure that you sufficiently diagnose for your procedures is going to be instrumental for you in minimizing those types of claims related errors. But also when you are requested for records, if you're in an audit, you're in a much more sound place to be able to communicate with the payer and combat that denial or that rejection, whatever that may be, because you have clarified what's taking place with your patient on that day and why. The next thing I would tell you is insurance has expired before the patient's visit, and this is a controllable error that happens far too often. So your best option to minimize this moving forward is, again, to make sure that when patients call in to schedule, it's a part of your screening questions to ask the patient if there's new insurance that they have for this year, or if there's new insurance that you should be entering for billing. Or when they come into the practice and they're checking in, ask them, do you have new insurance since your last visit? Make sure you're communicating that to them because they simply won't often or won't always remember to provide that to you. And of course, this causes paper claims will come back a few weeks later, either basically a paper-like rejection letting you know that the patient can't be identified or insurance has terminated. And then your electronic claims, depending upon the payer and the clearinghouse, could reject it immediately that the coverage has terminated, or perhaps you'll get an ERA or EOB soon down the road letting you know the patient's coverage has terminated. So this is a largely avoidable issue that costs practice a lot of money. And I would just, again, remind you, once that happens, you're in the position that you're either having to start calling the patient to ask them to give you that current information. I've even had where patients are reading cards over the phone to practices and something gets read wrong, typed in wrong, and it just causes too much room for error, which ultimately causes the practice to lose time and lose money, and then you're waiting to get paid. So super avoidable error, but there's definitely ways to very easily plug that hole almost 100% of the time. The next thing I would tell you is making sure that you're collecting your copays, coinsurances, and deductibles at the time of service as best as you can. what's so profound to me is that I have often wondered or felt that practices don't always recognize immediately how, and I know that you do, but at the same time, I still often feel like practices don't always recognize the value of their front desk, because this person has control of the total amount of money you're going to collect on a single day in practice every single day. So if this person isn't equipped with the appropriate tools, the appropriate information, the appropriate training, the communication techniques and language you'd like for them to use, then you're going to find that your over-the-counter collections are not nearly as healthy as they should be. And as we know, the older the money is, the more challenging it is to collect. So make sure that you truly consider the possibility that this role has really its hands on the reins of your practice more than what we often think about or recognize. And how powerful is that, to be able to be the one person or a couple of people that are ultimately deciding how much cash flow that practice is going to have on any given day. So make sure that you take the time to equip those people with the tools, the training, and the confidence they need to make sure that they're properly collecting copays, deductibles, co-insurances, self-pay amounts, amounts for your products and supplies and nutrition, all of that kind of stuff that is going out the door of your practice. So those are all controllable errors that I continue to be asked about. And again, every single one of them will make an immediate difference on your practice cash flow for the day. Here's a few more controllable errors for you. Chart notes aren't available for a specific data service. This happens to me sometimes. And this is just, sort of a red flag or to the doctors out there that if you happen to be one of those that just gets behind on your notes, needs to catch up, please make a point to make sure you're getting your notes done for your patients every day. One of the most challenging things that some CAs reach out to me is because they do get a lot of record requests. There's some payers that are just known for being those payers that are going to be requesting records on one or more line items. And if there isn't records to submit, then this is causing your practice to lose money or have delayed money. And it's not a position any of us want to be in, but it also adds to our to-do later pile as a biller or a CA that's responsible for that. And it's money that we know could be in motion, but instead it's sitting stagnant in accounts receivable and aging, and there's nothing we can do about it until we have those notes. So please make sure that you're getting your notes done properly. Next, delivering care for a patient with insurance that you do not accept. I have had this happen an awful lot over the past 4 or 5 months, where practices have the most common example is Medicare and Medicare Advantage. So I just want to quickly explain, these don't go to the same payer. If it's Aetna Medicare Advantage, then that claim is going to go to that Aetna Medicare Advantage plan. If it's Medicare Part B, then it goes to Medicare Part B. If it's Railroad Medicare, then it goes to the Railroad Medicare billing address, which is the Palmetto address. Make sure you know that. The easiest way is to look at the cards. So make sure you're having copies of your cards. But don't just assume, because our patients often tell us when they call in, oh, I have Medicare, but we don't find out until, especially if we're only collecting their insurance information from them over the phone and we don't have actual copies of cards, we're finding out claim practices are submitting claims to Medicare for those to reject because the patient can't be identified. And then the practices are confused as to why that's happening. Most of the time, it's because it's actually an Advantage plan and patients don't understand the difference. The other part also is that many Advantage plans out there don't have chiropractic coverage unless the provider is a network provider. Not all, but many of them. So this is something that you would need to check on to know if you're a network provider of that particular plan. If you're not, you're going to be miscommunicating to your patients, most likely under collecting from them because you're expecting a payment from an insurance company, only to find out the hard way that you submit the claim to the wrong payer. There actually is no coverage and the patient is responsible. So time's money, and then you're billing your patient and trying to explain to them how the error happened. So definitely avoidable, but happens a lot. The next thing I would tell you is Blue Cross, Cigna, and ASH. I've been getting this an awful lot too. Verifying benefits is really going to be the only way to know if you're submitting claims to ASH or Cigna or Blue Cross Blue Shield. So as we know, we have Blue Cross, Cigna, and we have Blue Cross and Cigna ASH. those go to different payers. So your electronic claims could reject or ultimately deny if they make it through your clearinghouse. It depends really, as far as the clearinghouse is concerned, as to the capabilities of the clearinghouse being able to identify that misrouting error. But otherwise, it's a misrouted claim. So if you submit a claim to Blue Cross Blue Shield that was actually supposed to be routed to ASH, the claim isn't going to be able to process. It's going to come back to you. If it goes by paper, it's going to come back weeks later, letting you know that the claim was misrouted. And then you're in the position that rather than having that money in your business operating account, you're having to correct the payer information and reroute the claim to the proper payer. So verify your benefits and know that. I've actually had a few practices over the past, I would say 3 to 4 weeks, that have just been bombarded with that and lots of corrections to make. So it's avoidable, but as a result, those 2 or 3 practices had just a reduction in their cash flow, and because they had a lot of those patients where the claims weren't routed properly, and it's definitely avoidable. Just make sure that you are verifying benefits to have that information. Next thing I would tell you, as far as electronic billing, make sure that you're eligible to electronically bill payers. There is an enrollment process through most clearinghouses that would require you to complete a couple of steps to be eligible for submitting electronically to particular payers. So if that's a process your clearinghouse requires, and instead of doing that, you just assume, okay, I have an electronic payer ID, I'm just going to submit all these claims electronically, you may find that you have an awful lot of rejections from 1 or more payers because you haven't gone through the electronic enrollment process. So make sure you know that. Collect your rejections. If you find that's a reason you're being rejected, you can quickly remedy it and get those claims back out electronically, or at least drop them to paper and get them moving so that you can get your remittance back more quickly. Next thing I would tell you that I didn't add to my slides, but is an error that happens, is there are some payers out there that require, if you're submitting by paper, the red and white official claim form. Most of our payers, if you print to black and white, our Blue Cross, Cigna, United Healthcare, if you submit your claim on black and white print, then it's going to process just fine. However, if you're submitting, and if you're eligible to submit to Medicare, Medicare requires the official red and white form. TriWest, Department of VA, anything with the Veterans Administration, you have to have the original black and white form. And the other one is ASH. If you're submitting a paper claim to ASH, you have to have the official original red and white form. A black and white copy won't be accepted. And what you'll find is those will be all mailed back to you with a letter letting you know you have to use the official form. So make sure that you're aware of those things too, because that, again, is a tremendous amount of delayed money for some practices. So really, by going through all of the things that I've been sharing with you today, these, again, the common questions that are coming in, and there's many of them that come in, but I was trying to put together some that would really give you some immediate action steps that are going to help you chip away and find that money that's just within reach, but it's just sitting there waiting for a little bit of attention from your practice before you can have that money in your business operating account as it should be. The next thing I would tell you is EOB issues that practices have. I'm going to quickly go through these and explain why it's so important to read the EOBs and show you how to read these EOBs so that you know for sure what you're looking for on yours. This particular one, first, let me just quickly explain. Every EOB has an adjustment and remark code. On either the very bottom page or the back page of every EOB is a key that tells you what all of those adjustment and remark codes mean. This gives you all of the information that you're likely to need as to why the claim processed, how it did, by individual line item. So with this particular example, this particular claim was submitted and it was one line item was denied. And this is why it's so important to never just read and post the service line totals on EOBs and then call it a day, but be attentive toward those individual line items so you can see how every single line item is processing, because if you're not, I'm certain that you're losing money on some of those claims. But this particular one was denied. The 99203 was denied, saying that the procedure isn't paid separately. So a lot of practices I have noticed would think, oh, darn, there must not be coverage for this. But if you look closely, you'll see that the 99203 is missing the 25 modifier. So by simply correcting that, this practice was able to get reimbursement for that. But this is a controllable error. So first we want to catch it on the front end before the claim is sent out, but things happen and things get overlooked. Even to the best of the best, there's just a lot of things to look at and a lot going on with the billing and collections with practices. So you need to make sure that you have a good way on the back end, the receiving end with your EOBs, to check those to make sure that everything processed as it should. Keeping in mind too that even clean claims submit don't always process properly. So read your individual line items. This one was able to be fixed and the practice was able to get paid for that. The next one I have here just goes to the importance of pre-certification. This particular practice didn't do verification of benefits, and when the biller moved on from the practice, the doctor was left to sort of learn how to do it himself. And as a result, he was going through his EOBs, trying to sort of understand what to do, where to pick up, and for where she left off and that sort of thing. And he comes upon this particular denial that was extremely alarming to him. And this one just simply says that the reason that the claim was denied because there was no pre-authorization obtained. So the practice confirmed that certainly there definitely was no pre-authorization obtained. They didn't know that they needed pre-authorization, but being a network provider, he had to write off all of these charges. So he essentially treated the patient for free, and anything he collected from that patient on those visits, as far as the co-insurance or copay he thought they might be due, had to be refunded to the patient. So not only did they lose anything that they had thought was coming due from the insurance company, but anything that the patient had paid, they had to refund as well. And then, of course, confess the error to the patient and get pre-authorization handled properly so that this type of thing didn't happen again. The next one I have here is really a duplicate claim. And this is just saying that this EOB, the duplicate means this has already been processed. So this means either the practice was really behind with posting or they didn't receive something. Either thing could happen. The duplicates do happen sometimes, but what you don't want to do is have a lot of duplicates that you don't know what's being paid and what isn't being paid. So this is definitely calls your practice to action for a proactive step forward as to, I need to log into my payer portal to see why this claim was denied as a duplicate. I need to find the original, or I need to call into the IVR, the electronic automated system, or speak to a person to get the details of this processing, because I don't know what it is. That's either money your practice has that you don't know you have. Perhaps you were requested for information. Perhaps the patient was requested for information that wasn't received. Until you look into it, you simply don't know. The next visit here had a different reason code, and this one just says that the patient had exhausted their benefits or exceeded the limits. And this is something, again, you don't want to be in the position of finding out after the fact, because most likely you have under-collected from your patient, most certainly have communicated coverage and benefits differently to your patient than what is reality. And you need to know when insurance benefits exhaust, so you're not spending the time to pay someone to take the time to submit claims that aren't going to pay anyway. This should be a self-pay patient at that point, where they're paying the balance due over the counter and nothing is falling back into the billing department or accounts receivable. The next one I have here is, again, going to the point of why it's necessary to read every line item. You'll notice on this particular claim, the manual therapy was denied for the request for records. A lot of practices don't recognize this, and here's your opportunity to submit the notes with a short cover letter, just letting the payer know that records have been provided per the request of the payer, for reconsideration or for consideration of this particular service. So making sure you have good notes that explain why you're doing and what you're doing is necessary. But if you're only posting the bottom line item, then if you're posting only the totals, you're missing the opportunity to get payment for charges that you could be missing. I will tell you, I have submit records on many of these manual therapies this is United Healthcare actually, and a lot of them will pay. Not all of them by any means, but a lot of them will. And I think it's most certainly worth it to make the attempt if you believe that your documentation is sound enough to define and support medical necessity. Then it's definitely worth going after that reimbursement that otherwise you wouldn't have if you didn't know that it was requested, or if you didn't submit that. The next one I have here, this is also a United Healthcare claim, and you'll see that this was actually a paper claim. The practice told me they submit by paper to United Healthcare, But it wasn't until a few weeks later that they received their EOB back, and one individual line item was denied, and the reason code just simply says that this particular service code isn't allowed. There's an insufficient service code. But if you go to what I was speaking of a few slides past, that 97014 shouldn't be on your United Healthcare claims. It needs to be the G0283. Keeping in mind that this claim I actually pulled before the United Healthcare GP order came through or request came through. So the GPs now would have to be on there also for this to be a clean and well-processed claim. But for the purpose of this one, that 97014 should be quickly replaced and corrected with G0283 and sent back out the door. If you're missing that, then you're missing that money. In conclusion here, as we go ahead and close, hopefully I've given you several of different things to think about with your practice and all of those different many of the different moving parts of your revenue cycle system. Certainly questions that I'm getting all the time. So I would assume that many of you have those same types of questions, or perhaps your CAs do as well. But just to let you know too, the other questions that are coming in on the C Help Desk, I get lots and lots of HIPAA related questions and compliance questions. I also did OSHA certification a few years ago and found a extreme interest in how all of the different moving parts of OSHA works. And I do believe in order to be fully compliant, practices should take note of that. Not to mention with the COVID-19 that we're dealing with right now, OSHA is certainly of interest in that because their primary objective is workforce health and safety. So there's more than likely going to be some things we're going to have to implement to best ensure that for our workforce. So I have had a few questions on that coming in, trickling in, I guess, on this topic. Most is the revenue cycle stuff. I get asked a lot of questions on what's my state rule, what's my state law, how do I find this information in my state? And of course, I don't know all of the answers off the top of my head, but I do have a passion for being able to quickly find them. And so I do, go right into the trenches to get that information, which ultimately saves your practices time and money. But also these pieces that are on your to-do list are getting checked off rather than being set to, I'll figure it out later, or let's just take a stab at it and hope for the best. So I pull that information. Something that's interesting that you might want to know about also is when I answer those questions, you're not ever just getting here's my summary for you, but you're getting the official resource. So I will send, if it's the Federal Register, the state guideline, payer policy details, whatever that might be, I send you the references and resource so that you know you're never just taking advice or saying, well, what Brandy said, here's how I know because this is from the Centers for Medicare and Medicaid Services, or the Federal Register, or the payer policy, or wherever that resource might be. Also, I get lots of questions on documentation and medical necessity and just general coverage details by individual payers. And so I find myself oftentimes pulling payer policies for practices, sometimes for their individual state, sometimes more broadly, but to send those details to them so that they can see what the overall expectations are from the payer, because sometimes denials come because there's something incorrect with diagnosing, coding, or the patterns in billing in general based upon the requirements of coding for individual payers. Most of the time, these things can be quickly identified. So I pull a lot of payer policies so practices have those reference. And of course, lots and lots of questions on accounts receivable, collections, coding, billing, modifiers, diagnosis, all of those different moving parts of your practice that we all know that we need to focus on, that we don't always have the time because you're busy doing what you're busy doing to take care of your patients. And so that's ultimately what I do as your virtual CA. And quickly, just to close, I wanted to, I guess if there's time for questions and Christy would like me to answer some of those, you can learn more. I'll flip back to this slide. If you want to visit my site, thechhelpdesk.com, you can see really how it works. But the on-demand CA is really just no contracts, no coaching, no, I won't send you to here, watch this really long video to, gain this information that I'm sharing with you, but I really just answer your question and here's the link to your resource. And it's on demand, unlimited, as a very well certified virtual chiropractic assistant for your practice. So with all of that, I can go ahead and conclude, and Christy, pass back to you.
Thank you so much, Brandy. We do have a couple of questions, except that somehow I got booted out. Let me refresh my. Let's see if we can see stuff. Okay. So it's a good thing I log in multiple places. The first question is, if we are in network as an insurer, do we have to use telehealth if it's a covered service, or can we make it self-pay for patients?
If you're in the network, so a couple of things with the telehealth that I would just tell you is telehealth ordinarily was fairly limited, but because of all of the guidelines and, well, actually because of our world circumstances right now, telehealth is a very rapidly changing area for billing and coding. So my best advice to you on that is to look at your individual payer to see what guidance they've given on telehealth. Many of them have already issued some sort of policy guideline, but in general, if your patient wants to self-pay, you do have the option to, actually you have to do what the patient tells you that you need to do. If there's no coverage for telehealth, then certainly your patient would be self-pay, but otherwise look at their policy guidelines. But by and large, as an in-network provider, the patient is always going to first take precedence. And of course, if there's no coverage, then you're not required to submit a charge where there is no coverage anyway for telehealth.
Wonderful. Okay. Is the GP modifier required for both UHC commercial and Medicare therapies?
Yes, that's correct. So the GP modifier is a Medicare modifier, but United Healthcare has adopted it for their use. A couple of things I would just quickly tell you about Medicare is just keep in mind that you aren't obligated as a Medicare Part B provider to submit to Medicare for charges that are statutorily excluded from Medicare benefit, meaning everything other than the spinal adjustment is your x-rays, exams, re-exams, and all of your therapies, you're not obligated to submit those because they're statutorily excluded. However, the couple of times that you would want to is if the patient says, you know what, I'd like this to be submit anyway, you have to do what the patient requests. Or if the patient has a secondary insurance where it's a full secondary insurance where there is additional coverage, not just your supplement with the 20 that pays the 20% of covered Medicare charges, but the secondary where there could be coverage and payment for that, then you'd of course want to submit those to Medicare so Medicare can process properly and deny them, so the secondary can process and reimburse you. But otherwise, you don't have to submit those. But if you choose to, because the patient is asked or there's a secondary or just that's your practice policy, so you're going to bill it, yes, the GP modifier needs to be appended to all outpatient therapies, as well as the GY modifier for Medicare, because that tells Medicare, first, this is an outpatient therapy, and then secondly, this procedure is statutorily excluded from Medicare benefit.
Is the modifier used for 97139 or is it payer dependent?
The 97139 is it's an unlisted therapy. So for United Healthcare, you would submit that with the GP because it is an unlisted therapy. However, for your other payers, you wouldn't use the GP.
Awesome. So I just, we had a couple of questions too about telehealth, and I just wanted to remind everybody that we did a webinar on telehealth that is really in depth on how to do telehealth, what telehealth codes there are, how to, with links to access telehealth rules and regulations in your state. And you can find those by visiting the archive. Somebody just asked for the link for the virtual CA. I just put that in there. Hold on one second. It is www.helpdesk.com. And y'all, I'm telling y'all, I utilize the help desk all the time. Brandy's my go-to person, partially. And again, one of the things that I love about utilizing her is because she always provides you with the reference material so that you can see and know without a shadow of a doubt that the information she's providing you is, true and correct. So I just want to remind you too, we have another webinar tomorrow because we're doing webinars all week long because she brought up OSHA. And it is something that we have not thought about a lot in chiropractic, or didn't always believe that it applied to us. But we will be walking you through how to create your own OSHA policies and procedures in your practice, which has never been more important. So make sure you register for that at ChiroHealthUSA.com/webinars. I also included that in the chat box. So if you scroll down, you should be able to see that as well. click the link to register. Again, if the time's not convenient for you, just remember every webinar is recorded. A link to the webinar recording is sent to everyone who registers. You can also visit the archive anytime to go back and look at them. Okay, we're going to close with one last question. When I bill 97012 to United Healthcare, it always gets denied. If I use GP, should it get paid?
Yes, it should, because typically the mechanical traction is a covered procedure. With United Healthcare, you have to have the GP modifier for it to process properly. One thing that I would tell you regarding the mechanical traction code is a lot of practices use the 97012 as part of their routine. This is just what I do every visit with every patient as part of what we do. So please remember that you still have to meet the medical necessity standard for this procedure, just like with every other procedure. So 97012 is one of those that can in time begin to be denied simply because there's not medical necessity, or there's questionable medical necessity. So make sure your documentation is good, but yes, submit it with the GP. It will more than likely process and reimburse to you, but ultimately we also want to be in a position where we can keep the money we make too. So just make sure your documentation is sound.
So if you have any more questions like this for Brandy, again, her services are so reasonably priced. Like I tell her all the time, she's just not charging enough. Yep, I said it. And I don't say that very often. So make sure you go visit the thehelpdesk.com. You can click here to get started. It gives you the payment options. And then you have access to her so that when you have those questions because something got denied from United Healthcare, you can go to her. She can help you to work that out and give you the information from United Healthcare to tell you why you need to use the GP modifier. So again, thank y'all so much for being part of the webinar today. I love spending my Tuesdays with y'all. I'll be back tomorrow at noon Central Time, 1 Eastern, to talk about everybody's favorite topic these days, at least, OSHA. So y'all have an amazing rest of your day and a fabulous week. And until next time, see you later. Bye, everyone.